Hi everyone, my name is Lindsay and this is my presentation that I've put together in PowerPoint. It is, if we're looking at the title slide, it is Evidence-Based Interventions to Improve Cognition for Military Veterans with PTSD. And then if we move to the next slide. Okay, by way of introduction, according to a recent VA annual report, 7 out of every 100 military veterans have PTSD, which is post traumatic stress disorder. PTSD is the acronym. This amounts to about 7% of the population in question. The most recent wartime era of Operation Enduring Freedom and Operation Iraqi Freedom. I had to think about that for a minute. That was the war theater that my husband came out of. He was in the United States Marines from 2002 to 2006, so about 4 years of service. He was over in Iraq and Afghanistan for 2 tours of duty. And he did get medically retired. He is diagnosed with actually at 100% for PTSD and traumatic brain injury, which is also known as TBI. Just as, but again, by way of introduction, TBI is another one of the hallmark injuries, service-connected, specifically disabilities that have come out of this wartime theater of post 9/11. So issues with cognition, which occur at varying levels of severity, affect every aspect of life for someone with a diagnosis of PTSD. This is whether you are a military veteran or somebody out there in the community that has not served in the military. Some of these consequences involve difficulties transitioning to civilian life. It is already hard enough for these men and women when they come back from living a very regimented, very unpredictable, honestly, very traumatic lifestyle to having to come home and deal with all the difficulties of almost coming down from that experience, if I can put it that way, and coming back with disabilities. I mean, for my husband alone, it took the VA healthcare system until 2014 to actually recognize service-connected diagnosis of PTSD. And to get him to that 100%, that took us about 3 years of claims. Also, there is an inability to stay gainfully employed. This is not true of every single veteran. I don't have a statistic that's recent to share with you, but I can tell you from my husband's experience, he was in and out of so many jobs. I mean, even with the Americans with Disabilities Act, really very little in the way of accommodations were made for him. And even if they had made those accommodations, I don't know if it would have stuck. So he actually has not had a job since, I believe it was 2013 when he worked his last part-time position. And actually, I don't work because I'm his caregiver, but I will get to that in a minute. Also, a difficulty or lack of meaningful relationships, whether they were established before entering the military, during, or even after. And an overall decrease to the quality of life. These are very, very common negative consequences of being diagnosed with PTSD in the military. So I'll move on to my purpose. My fellow researchers and I wish to educate everyone concerned, no matter who's part of our audience, so to speak, on 2 things specifically: the impact of cognition issues in the lives of military veterans with PTSD, and the effective and evidence-based interventions that can be utilized to improve their quality of life and try to mitigate the symptomatic impact of PTSD cognition difficulties. So one of my studies was a quantitative meta-analysis that was published in 2015 by a researcher by the name of Dr. Scott and others on his team. I believe there are 4 or 5 other names mentioned that you can find on my references slides at the end of this PowerPoint presentation. And I quote, found statistically significant, stronger associations between PTSD and cognitive impairment in individuals seeking treatment. This illustrates that cognition difficulties are a largely affected area for those with PTSD, and it also shows you how widespread the issues are that go well beyond the purposes of this research proposal and really are still being studied to this day. In addition, within that same study, they analyzed, as part of their meta-analysis, at least 60 cohort studies that dealt with PTSD, and PTSD was associated with the worst performance on objective cognitive tests assessing 9 different cognitive domains. So it shows you how far reaching the effects on cognition are when it comes to PTSD in the individuals that have that diagnosis. So, as a literature review of some of the articles, I tried to pull together some of the common themes or common trends, methodologies that they have. I don't have much information as far as the theoretical models, but I'm sure that if you read through them yourselves, look back in your notes as a social worker, I'm sure we can figure this out. So psychotherapy in its different forms has long been utilized in the treatment of PTSD. This is the VA, this is community care, this is specialized care on, Native American reservations. I mean, psychotherapy is a common frontline intervention when it comes to dealing with PTSD. So, for one, all of these interventions are conducted in clinical settings with strict measures to protect privacy. By way of, it's a little bit of a rabbit trail, but it's worth it to mention this. Hypervigilance and paranoia are two very common components to PTSD. These two things can create very deep trust issues, whether it comes from the medical team through the Department of Veterans Affairs and their various outpatient clinics and then the main medical centers in the larger cities, or when you're dealing with a caregiver, family, friends, especially when they meet somebody new. So having those strict measures to protect privacy are of the utmost importance when you're dealing with people with PTSD, especially men and women separating from the military. Also, various scales like the PTSD checklist and the DSM-5, that's also known as the PCL-15. Likert modalities, and I believe the trauma-related cognition scale, the TRCS, and by way of acronym, I believe that is a Likert study format. You would have to go back and check. Unfortunately, I was not able to obtain copies of these scales. I actually needed to pay for them. So hopefully, as I continue my research, maybe I can find an example or two of at least one of these and put it in the appendix for my grant proposal that we're putting together. In addition, both linear and nonlinear data analysis is conducted to establish patterns and identify trends. So since 2006, there is a Cameron study that was actually just published, I believe it was earlier this year, that the VHA, which is the Veterans Healthcare Administration, undertook at a national level to implement the use of two main types of psychotherapy. These are prolonged exposure, or PE, and cognitive processing therapy, which is also known as CPT. And I noticed I did not put that in my presentation, but thought I would mention that also. And then also the VHA utilizes these and other psychotherapies, as I mentioned earlier, frontline measures for treatment of PTSD, and their successes at varying degrees. It depends on so many factors that go well outside of my ability to explain them. But it's affected, honestly, by their age, the level of difficulty they have doing activities, even their employment history, even the fact that whether you're a male or a female profoundly affects how you handle a PTSD diagnosis and then learning how to live with it and adapting. So on to our next slide, the effective interventions. I've pulled together a few quotes. So CPT and PE have strong efficacy and are effective in patients with complex presentations and comorbidities. So within the last few slides, I have mentioned that TBI, or traumatic brain injury, is another hallmark service-connected disability that many members of the post 9/11 wartime theater were diagnosed with. So when I talk about comorbidities, that is having PTSD, TBI, and then obviously you can have any number of other mental health or physical disabilities or just conditions that you have pre-existing or that get diagnosed at time of separation of service. So complex presentations, all of these mental health conditions can interact with each other to the point where you can't tell what symptom is connected to which diagnosis. So a good amount of research attests to evidence-based treatments like CPT and PE are responsible for large reductions in PTSD symptoms, and even with depression, which is often associated with PTSD. And then last, by, I believe it's 4 or 5 different studies down there, given that PE or prolonged exposure therapy has historically demonstrated robust treatment effects among patients with significant comorbidity. So, as I'm doing a literature review and I'm looking through all these articles, it is really showing that prolonged exposure therapy as part of a psychotherapy treatment is very effective in mitigating these. When you're talking about PTSD, this is not a diagnosis that can go away like a broken leg can heal. This is something these men and women will have to deal with for the rest of their lives. So it is important to have interventions that will help as much as they possibly can for everyone involved. On to our next slide, effective interventions. My approach is a mixed use methods that study that will utilize both quantitative and qualitative data. I plan on utilizing random sampling of at least 200 people out of the population of military veterans from that OEF, OIF wartime era being treated specifically at the Cleveland VA Medical Center. I decided to really focus my study on just this. I wanted to do a smaller study because of the interview techniques, because of the different levels of severity. The study would already cost quite a bit just to put everything together to make sure, all of the supplies are together, paying for the computer programs. I wanted to try to keep the population being studied down to a minimum, but still enough to equate with results that can be generalized. There are 4 different skills that I'll use to evaluate progress on a biweekly basis of those that are randomly assigned to psychotherapeutic groups. Some of those scales that I will use do include that PCL-15. They also include a couple of other really symptom trackers that will be administered. I believe I have it at 2-week levels every 2 weeks doing that. Excuse me as I go back through and try to do that then. Okay. So I was able to look up a couple more articles specifically dealing with prolonged exposure and with cognitive processing therapy. And one of the more recent ones suggested introducing ITPs or intensive treatment programs. I've decided to use the VA mindfulness app that will be utilized in addition to twice weekly sessions of CPT or PE. Those weekly sessions will be randomly assigned, and it will not have any ability to overlap. I believe that pursuing CPT and utilizing the ITP of the VA mindfulness app will show different variations. I'm trying to extract as much information about patterns and trends as possible. The study is meant to be 6 months in length, and follow-up will be at least 6 months after to see what the level of effectiveness is months after treatment has been administered. Conclusions that I hope to withdraw from the study itself. Discovering which psychotherapies in conjunction with those ITPs are most effective with the differing levels of cognition issue severity. Further research is going to be needed on a larger scale and in a longitudinal manner to see how these evidence-based interventions of psychotherapies hold up over an extended period. The longitudinal study is perhaps the longest and honestly the most expensive because you're doing it at such an extended period. My husband and I are actually part of one through Congress. It was assigned for 10 years. That is a common length for a longitudinal study, and it's literally discovering just specifically how PTSD affects the lives of the veterans diagnosed with it and with the caregivers themselves. And last, a better understanding of PTSD itself and how cognition difficulties trend over time in different individuals. I will say this, there is no one treatment or combination of treatments that will completely eradicate these issues. Like I said, PTSD is a lifelong diagnosis. These men and women will have to deal with it for the rest of their lives. Another trend I noticed in some of the limitations of these is that often several rounds of PE, CPT, CBD, CBT, excuse me, which is cognitive behavioral therapy, any psychotherapy, it is not abnormal for these men and women to go through multiple rounds. This is just something that I've read as my role as a caregiver. I'm a part of a VA caregiver support program. That is a program that allows me to stay at home and care for my husband. They do provide medical coverage. Some services are covered. I can go to the doctor at the VA for pretty much anything from primary care to an acute visit. So, with that being said, this is a topic that is very, very close to my own personal experience. Um, it has been very eye opening to research PTSD as a total, and to learn more about this condition and about some of the therapies that can help. Again, there is no one size fits all approach to this. I know that the medical community at large has to synthesize, 12-step programs or lengths of particular therapies. This is to control costs. This is to try to serve as many people as possible. I understand that. But one of the other concerns is that there is also a high incident rate of not just suicide alone, but suicidal ideation. When these guys have to wait months for an appointment, possibly years, to get a diagnosis. So they can not just, this is not just talking about being compensated. This is talking about them being heard. It's important as a caregiver to be an advocate, and that's why this study is so important to me. The last two slides, which I believe are 8 and 9, list all my sources. Most of these are referenced in these few slides. Some of them I did not. There is a link that I was not able to create a hyperlink, but you can copy and paste that into your web browser under your Moodle login, and you should be able to look up those articles and get any further information. You are welcome to email me at lrpauler1@malone.edu if you have any further questions. If you want me to email you a link to the study that actually works, I know sometimes technical issues can happen. But thank you for listening to me. I hope that you got something out of this presentation, because I know I did.